Well, hey everyone, welcome back. Again, my name is Scott Glazier. I am one of the ultrasound fellows at Massachusetts General Hospital, and I'm here with another interesting case. Today I have with me a special guest, Dr. Nick Shermer.
Bonjour tout le monde.
Nick is from Montreal, Canada, and is a guest with us here at MGH for the next couple of months, and was working with Dr. Vicky Noble and had a great case, and so I want him to come on and talk to us about the case. So Nick, please take it away.
Right on. Thanks, Scott, for great introduction and for getting me on this. So I'll get right to the point. We had a gentleman. He was 45 years old, and he was driving his truck, and he ended up smashing into a parked car. Kind of bizarre, and luckily he had some excellent bystanders next to him at the time who ended up pulling him out of his truck, noticed that he was pulseless, proceeded to begin with CPR, eventually he ended up getting shocked by EMS, and his pulses returned, and he was brought into the emergency department. And so we were there at the initial evaluation, and of course our first test that we got was, this EKG. And I mean, it's not that remarkable. It's not a slam dunk case. I don't know if you'd agree, Scott.
Well, I don't see tombstone or
No.
obvious. I mean, it looks a little, maybe there's something in the anterolateral leads, but it's not a 100%, yep, STEMI, let's go.
Exactly, and that was our issue. I should note that, there was multiple different EKGs and there was some dynamic changes, but, it was concerning enough, especially given the history, that we called immediately cardiology and they were on their way down.
Right.
But you can imagine that they weren't so convinced when they saw this EKG.
I know it's sometimes because of other issues that they will not take a patient directly to the cath lab, even if you have a good story.
Right.
And so I assume that they wanted maybe a troponin.
Oh, they wanted not just a troponin. Why would you stop there? CT head, a urine tox screen, why not look for TB while you're at it too?
Yeah.
So we, thought about doing that. Actually, Vicky thought about doing that, but I really wanted to do an ultrasound, of course.
Yeah, Vicky's not too crazy
right.
about ultrasound.
So after bending Vicky's arm and running to go get an ultrasound and making my way through all these lines and people around me, I ended up putting the probe right on the chest, and that was the first view that I saw.
So here we have a parasternal long. We have the left ventricle right here, the mitral valve. The left atrium is to your right, and this is the LV outflow tract. You can see the pericardium deep in the image. No clear pleural effusion or pericardial effusion, but if there was something, it would be small or minuscule. So.
Right, there's nothing there to explain why this guy had his symptoms. And globally looking at it, it looks like he has a relatively good EF. I don't know if you'd sort of agree.
Yeah, we skipped the parasternal short, and the next image we have is the apical 4 chamber.
Right, so as soon as I got this, actually cardiology had just walked into the room. And so I got this image, and we were both staring at the screen at the same time. And we kind of just looked at each other and nodded in agreement. Yeah. And so let me just highlight to you what we sort of were agreeing about. And if you look at the ventricle, at the apex of the ventricle in the apical 4, it's not moving nearly as well as, for example, the septum or the lateral wall. And so that's classically what we would describe as a focal wall abnormality. And cardiology saw that and basically walked out of the room and immediately activated the cath lab.
And you compare this to a normal image over here. This is the normal image. You see here that the apex is working pretty good.
Right, right. All in conjunction with each other's symmetrical movement and good EF, apparently.
Yeah. So, talking about the cath lab.
Well, so he goes to the cath lab. Of course, he's still flailing, he's still altered, and he's being a real, whatever. But we get him out of our emergency department, so that makes everybody happy. And in the cath lab, he does, in fact, have a lesion. He has a 90% stenosis of his LAD. And just for some bonus points here, you can actually have predicted exactly which lesion he would have gotten. And this is what we would use to sort of predict. Now, do you remember any of this? No, I never remember this.
Every time I see a focal wall motion abnormality, I always have to go back to images like this. And we did get this from the ultrasound podcast, Mike and Matt, because they really do outline the best, I think, on how to really tell which vessel you would consider to be included.
They have a great podcast on this, so all credit to them. And if you're interested in more information, you can go and look that up on their website. But as you can see, just as I was mentioning, his LAD was stented, and that's in fact exactly where he was having focal wall abnormality, right at the apex. And the same could have been, in a different context, true. So if you had an RCA, his septum would have been altered, and if you had a circumflex, his anterolateral wall would have been affected too.
So what do you think would have happened if you hadn't done the ultrasound?
Well, he would have started, interestingly, I didn't mention mentioned this beforehand, but after they got his pulses back, he ended up becoming violent with the EMS and punching everybody. So I'm assuming you probably would have started punching everybody else in the emergency department too. So luckily we saved ourselves a few bruises, and not only bruises to our body, but bruises to our ego, and saved him.
But it's also probably good for the patient as well because...
Oh, you mean the patient? Oh, right. Sorry about that.
Just because, who knows?
Oh,
maybe he would have arrested a couple more times.
True. Good point. Good point.
So,
we don't really care much about those things in Canada, but that's an excellent point.
But it's just great that, you have had to wait for blood work, maybe even a CAT scan, and you really were able to get him up to the cath lab in minutes.
This expedited his care, and time equals money, and sorry, doesn't equal money, but time equals heart muscle, and we certainly probably saved a lot of heart muscle there.
Well, thank you very much, Nick, again for coming and telling us about the case.
Yeah.
As always, you can email us at mghedus@gmail.com. Thank you very much.